Bismillahirrahmanirrahim. Quote of the day: be happy with what you have while working for what you want. Today, the topic of my presentation is occupational disease classification, pneumoconiosis, and I am presenting it under kind supervision of my professor, Dr. Sarah Afzal. Learning outlines: classification of occupational diseases, pneumoconiosis, Silicosis, coal workers pneumoconiosis, asbestosis, bagasosis, bicinosis, farmer's lung, and in the end, recent updates and MCQs. Learning objectives. In the end of presentation, participants would be able to classify occupational diseases and would be able to describe different occupational lung diseases. Now, classification of occupational diseases. First comes diseases due to physical agents, that is heat leading to heat pyrexia, heat exhaustion, heat syncope, cramps, burns, and local effects. Cold leading to trench foot, frostbite, chilblains, light occupational cataract, minor nystagmus, and pressure causing Caston disease, air embolism, blast. Noise causing occupational deafness, radiation leading to cancer, leukemia, aplastic anemia, pancytopenia, and mechanical factors leading to injuries and accidents factors, and electricity causing burns. Then comes diseases due to chemical agents, like due to gases, carbon dioxide, carbon monoxide, sulfur dioxide, hydrogen chloride, all these causing gas poisoning, and dust causing pneumoconiosis, inorganic dust like coal dust causing anthracosis, silica leading to silicosis, asbestosis, and acidosis due to iron. Then comes organic dust, cane fiber leading to bagasosis, cotton dust causing bicinosis, tobacco leading to tuberculosis, hair or farmer's lung due to grain dust, metal and their compounds, toxic hazards from lead, mercury, cadmium, manganese, chromium, and chemicals like acids, alkalis, pesticides, solvents, carbon disulfide, benzene, chloroform, etc. Then thirdly, it comes diseases due to biological agents like brucellosis, leptospirosis, anthrax, actinomycosis, hydatidosis, psittacosis, tetanus, encephalitis, fungal infections. Then comes occupational cancers like cancer of skin, lungs, and bladder. Then comes occupational dermatosis like dermatitis, eczema. Then comes diseases of psychological origin like industrial neurosis, hypertension, and peptic ulcer. Moving to our second topic, that is pneumoconiosis. Dust within the range of 5 to 3 pica is a health hazard produced after a variable period of exposure, a lung disease known as pneumoconiosis, which may gradually cripple a man by reducing his working capacity due to lung fibrosis and other complications. The hazardous effects of dust on the lung depend upon a number of factors such as chemical composition, fineness, concentration of dust in the air, period of exposure, and health status of the person exposed. Therefore, the threshold limit values for different dust are different. In addition to the toxic effect of the dust on the lung tissues, the superimposition of infections like tuberculosis may also influence the pattern of pneumoconiosis. Important dust diseases. These are silicosis, anthracosis, bicinosis, bagasosis, asbestosis in farmer's lung. As no cure for the pneumoconiosis is known, it is essential to prevent these diseases from arising. Now we are going to discuss each one by one. First up, silicosis. Among the occupational diseases, silicosis is the major cause of permanent disability and mortality. It is caused by inhalation of dust containing free silica or silicon dioxide. Its occurrence has been uncovered in various other industries, for example, mining industry, that is of coal, mica, gold, silver, pottery and ceramic industry, sandblasting, metal grinding, building and construction work, rock mining, iron and steel industry, and several others. Pathogenesis. The particles are ingested by the phagocytes which accumulate and block the lymph channels. Silicosis is characterized by dense nodular fibrosis, the nodules ranging from 3 to 4 millimeter in diameter. Now, these are the symptoms. The main symptoms that are due to continued exposure of silica are shortness of breath, fever, blurred skin at the earlobes or lips. And when the disease progresses, it causes fatigue, extreme shortness of breath, loss of appetite, chest pain, respiratory failure. And the people who are at risk, that is the at risk occupations, are construction, mining, sandblast, masonry, demolition, manufacturing of glass and metal products, plumbing, painting. Now, types of silicosis. These are the three types of silicosis depending upon the airborne concentration of crystalline silica to which a worker has been exposed. First is chronic silicosis, which occurs after 10 or more years of overexposure. And then accelerated silicosis that results from high exposure and develops over 5 to 10 years. Acute silicosis occurs where exposures are the highest and can cause symptoms to develop within a few weeks or up to 5 years. Now, moving to prevention. These are the main four preventive measures, that is substitution, engineering, work practices, and personal protective equipments. Let's discuss each one by one. Substitution. Substitution, it is the substituting the silica means using a different or a safer material in place of the silica containing substances. Um, it is true that in some cases not possible to use a substitute in place of silica, but for many operations such as abrasive blasting, there are many possible substitutes like aluminum oxide and ambient polycarbonate, cryogenic polycarbonate, beads, melamine, plastic, novaculite, and silicon carbide. Then comes engineering controls, that is keeping silica out of the air. If silica products must be used, engineering controls to be used wherever possible. This type of control involves a mechanical process to eliminate exposure to silica dust. Some of these controls may be very simple, as can seen in the examples below, like installation of a water hose to wet down the dust at the point of generation, install local exhaust ventilation during rock drilling, flow water through the drill system, install dust collection systems onto machines or equipments that generates dust, use of concrete masonry saws that provide water to the blade. Then comes work practices. That is what employees can do to reduce silica intake. If workers know about silica and understand the severity of its health hazard, they will be more likely to do the following. That is, knowing which work operations can lead to silica exposure, participate in any air monitoring or training programs offered by the employer. If possible, change into disposable or washable work clothes at the work site. Shower and change into clean clothing before leaving the work site. Do not eat, drink, use tobacco products, or apply cosmetic in areas where there is dust containing crystalline silica. Wash your hands and face before eating, drinking, smoking, or applying cosmetics outside of that exposure area. If using respirators, they should not be altered in any way. Then comes personal protective equipment. Personal protective equipment against silica includes respirators and masks. Respirators should be used only when the dust controls cannot keep dust levels below the recommended exposure level. There are many types of respirators, from air purifying to air supplying in from a nose and mouth covering to a full body respirator. And comes anthracosis, other name for this lung disease is coal workers pneumoconiosis or black lung disease. It results due to the accumulation of coal dust in the lungs and the tissues reaction to its presence. It is associated with coal mining industry. It takes 1 or 2 decades to cause symptoms, and it is divided into two categories: simple pneumoconiosis or coal workers pneumoconiosis, and complicated or progressive massive fibrosis. This is a comparison of two forms. The simple form, which is that is focal aggregations of coal dust laden macrophages, and patients have slight cough and blackish sputum. The complicated form occurs after many years of underground mine work, and fibrous scarring appears complicated. In complicated coal worker pneumoconiosis, and the other name for this, as we have already discussed, is progressive massive fibrosis. Okay, simple co-workers pneumoconiosis is said to exist in the presence of radiological opacities, that is, if it is present less than 1 centimeter. This is the main difference between the two types, that in simple co-workers pneumoconiosis, radiological opacities are of less than 1 centimeter, while in complicated one, it is greater than 1 centimeter or more than this. Then a simple one is benign disease if there is no complication accompanying it. And common symptoms are cough, expectoration of black in color, and dyspnea. And there is slight decrease in forced vital capacity and FE1 over FVC. And complicated cold workers pneumoconiosis is diagnosed when large opacity of 1 centimeter or more in diameter is observed in the chest X-ray, and pathologically it is corrected by large masses of black colored fibrous tissue. Symptoms are similar but more severe, and there is recurrent pulmonary infections in this type. The large lesions may cavitate as a result of ischemic necrosis or infection, and pulmonary function test reveals decreased FVC, FE1 over FVC, and increased residual volume. These are the symptoms in two types of the pneumoconiosis, cold workers pneumoconiosis. In simple one, initially the cold worker may not have any symptoms, and as the disease progresses, cough, wheezing, and shortness of breath start appearing. And if there is progression to complicated type, it has no cure. The main thing to remember is, and the symptoms are shortness of breath during physical effort, black sputum producing cough, producing milky gray, clear, or cold flat sputum, and bluish tint to fingernails and lips, trouble breathing, severe shortness of breath. Complications are abnormally high blood pressure, low blood oxygen, right-sided abnormal heart enlargement, fluid retention, heart failure, and pulmonary tuberculosis or COPD, swelling, inflammation in lungs, and lung failure. Now, byssinosis. Byssinosis is caused by inhalation of cotton fiber dust, that is textile and fiber industries. The chief symptoms are chest tightness, shortness of breath, cough, and wheezing, and typically occurs when patients return to work after a weekend or vacation. And smoking significantly exacerbates byssinosis. When detected in its early stage, that is acute byssinosis, it is reversible by eliminating exposure to the responsible irritant. When exposure continues, the byssinosis can cause permanent damage to the lungs, that is chronic byssinosis. Treatment. In the acute setting, patients are encouraged to consider alternative occupations or at least reduce the exposure in the work environment. Smokers should be encouraged to stop smoking. In the acute stages, treatment may include bronchodilator for symptomatic relief. Corticosteroids are best avoided for as long as possible, given only in severe cases. In chronic byssinosis, supportive measures like nebulizer use, home oxygen, physical activity, and breathing exercise helps in management. Now, preventive measures. These are the medical measures, engineering measures, and other measures of byssinosis. First is medical measures. It includes pre-placement examination, periodical examination, medical and healthcare services, notification, maintenance and analysis of records, health education and counseling, practicing good personal hygiene. In practicing good personal hygiene, it includes washing of hands and face before eating, drinking, going to toilet, smoking, and not eating, drinking, smoking, applying cosmetic in areas where it is produced, wearing protective clothes, and before leaving work, shower and change clean clothes, and leave the clothes at work. And engineering measures include designing of buildings and conducting air monitoring, and prohibiting of dry cutting and promoting wet cutting, and use of personal protective equipments and enclosure isolation, environmental monitoring. And in other measure includes legal measures, law compliance mechanism, cooperation between management and workers and their representatives, and a mechanism for the collection and analysis of data on occupational diseases, and collaboration with social security schemes covering occupational injuries and diseases. And training of health professionals in occupational diseases, as majority of medical practitioners lack training in occupational health and consequently lack the skills to diagnose and prevent occupational diseases. And moving to bagasosis, it is the name given to an occupational disease of the lung caused by inhalation of bagasse or sugar cane dust. The symptom consists of breathlessness, cough, hemoptysis, and slight fever. Initially, there is acute diffuse bronchiolitis, and skyga may show mottling in lung or shadows. There is impairment of pulmonary function. If treated early, there is resolution of the acute inflammatory condition of the lung, and if left untreated, there is diffuse fibrosis, emphysema, and bronchiectasis. The four preventive measures of bagasosis is dust control, personal protection, medical control, and gas control. Dust control measures for the prevention and suppression of dust, such as wet process, enclosed apparatus, exhaust ventilation should be used. In personal protection, PPEs like masks, respirators with mechanical filter, oxygens should be necessary. Medical control, initial medical examination, periodical medical checkups of workers are indicated, and bagasse control. By keeping the moisture content above 20% and spraying the bagasse with 2% propionic acid is a widely used fungicide. Bagasse can be rendered safe for manufacturing use. Now moving on to asbestosis. It is a chronic disorder of the lungs which results from continuous inhalation of asbestos fibers over a prolonged period of time. It results from the scarring of lung tissue by asbestos, and scarring obstructs the passage of air and makes the breathing difficult. The main symptoms are loss of appetite, clubbing of fingers and toes, crackling sound while inhaling, shortness of breath, persistent cough, chest tightness, chest pain, and it is a only cause of mesothelioma, which is a lung carcinoma. It is due to asbestos exposure. Now, chest radiograph findings are small, irregular oval opacities, interstitial fibrosis, shaggy heart sign. And the people at risk of asbestosis development are auto and aircraft mechanics, carpenters and construction workers, Navy seamen, shipyard workers. Preventive measures. First is use of safer type of asbestos, that is solite and amosite, substitution of other insulants, glass fiber, mineral wool, calcium silicate, plastic foams, rigorous dust control, periodic examination of workers, biological monitoring, and continuing research. Then the last occupational lung disease, farmer's lung. It is due to the inhalation of mildly hay grain dust. Greater than 30% moisture favors bacteria, fungi growth. Rise temperature 40 to 50 degrees centigrade favors thermophilic actinomycete. And polyspora finae is the main cause. And in farmers' lung, repeated attacks leads to pulmonary fibrosis and damage, and ultimately leading to cor pulmonale. Health effects of farmer's lung are inflammation of the lungs due to repeated exposure to the spores. Symptoms are chills, cough, fever, shortness of breath, and symptoms of chronic farmer's lung are breathlessness, cough, loss of appetite, weight loss. It is often reversible by avoiding additional exposure. Chronic form may lead to scarring of lung tissue. Investigation includes chest X-ray and HRCT. In chest X-ray, there are diffuse small nodules or infiltrates, sometimes ground glass change, apical sparing, and it is normal in up to 20% of cases. In HRCT, patchy ground glass change and poorly defined nodules. Prevention. It includes dry crops before storage, works in ventilated areas or outdoors, wet down dusty areas prior to working in them. Wet hay should be inside, key to stopping mold growth, and consider respirator. Now moving on to recent updates. First, this is the article published in PJCM. This was the research done in Pakistan in district Bannu. Frequency of co-worker pneumoconiosis in patients presented to chest outpatients department. The objective of this study was to find out the frequency of co-workers pneumoconiosis in patients presenting to chest OPD. The findings of this study were that a total of 223 male patients with age of 26 to 67 years with 7 to 27 years coal mine working history were interviewed, examined, chest x-rays, PFTs, and HRCTs were done. Out of 142, out of them, 142, that is 63.6%, were found to have coal worker pneumoconiosis, and 36.3 had no findings. Among these, 60% had findings on chest X-ray, and 39.9% had normal X-ray. PFTs were abnormal in 70% patients having restrictive, obstructive, or mixed pattern, and 66, that is 29.5%, had normal spirometry. HRCT findings were seen in 63% patients and had normal HRCT in 36% patients. Then this is another study done in Lahore, that is pulmonary function parameters among marble industry workers. The purpose of this study was to compare the pulmonary function parameters of workers in marble workshops and age-matched healthy individuals in the Lahore district of Pakistan. The study included 164 male individuals, 82 were working in marble workshops, while 82 were healthy individuals from the same community. As a spirometry for PFTs was done to identify and change in the lung function parameters, forced vital capacity, forced expiratory volume in the first, second, and FE1 over FEC ratio were evaluated. A statistically insignificant difference was observed between marble exposed workers and healthy individuals from the demographic variables. Lung function parameters in marble worker exhibited a highly significant decrease in FEC percent, FE1, and FE1 over FEC ratio when compared to healthy individuals. 71% of marble workers had abnormal pulmonary parameters, whereas 34% of workers had restrictive pulmonary impairment. Marble workers who had worked for more than 50 years had a slightly significant risk of developing abnormal pulmonary function. This is another study, that is frequency of silicosis and its relationship with dust and pulmonary function test in stone crushing industries workers in Peshawar. According to it, the true prevalence of silicosis is underestimated, as during its initial phase, the patient is symptom-free, and silicosis is the commonest occupational lung disease all over the world, but it is more frequent in developing countries, including Pakistan, where safe work practice among the workers is poor. This cross-sectional analytical study was carried out in year time in 204 male workers of stone crushing industries in the suburbs of Peshawar. Out of the 204 patients, 13 were suffering from simple silicosis, 4 from advanced silicosis, and 1 was having complicated silicosis. It was observed that a very strong association exists between length of job duration and smoking in the causation of silicosis. PFT's results of 152 were normal, and normal results were found in 30% of participants, and spirometry results of 26.5% participants showed a restrictive pattern and 3.9% showed obstructive pattern. A strong relationship was observed between the duration and intensity of exposure and PFT's results. Those who were working for 8 hours or more per day and those who were working for 10 or more than 10 years were having more deranged PFTs. Similarly, PFTs were more deranged in those participants who smoked heavily. Now moving on to multiple choice questions. MCQ number 1. Coal worker pneumoconiosis is a lung disease caused by deposits of coal dust in the lungs. Which of the following is a false statement about black lung? It results from inhaling coal dust or graphite over a long time. It is a type of emphysema. Symptoms are more likely in smokers. It can cause disabling shortness of breath.
B.
Yes, right answer is B, because it is not a type of emphysema. It is one of the interstitial lung disease, and there is scarring of interstitium, while in emphysema there is dilatation of bronchioles. MCQ number 2. Asbestosis is widespread scarring of lung tissue caused by breathing asbestos dust. Which of the following is responsible for the largest number of lung cancer cases among patients with asbestos? Cigarette smoking, genetic predisposition, having other lung disorders, levels of exposure to asbestos fibers.
D.
No, the right answer is cigarette smoking, because those people who have developed asbestosis are more prone to develop mesothelioma or other lung cancers who are already cigarette smokers. MCQ number 3. Mr. Ali has been working in a ceramic industry for last 12 years, develops fatigue, shortness of breath, loss of appetite, and chest pain. His chest X-ray shows ground glass appearance in both lungs. What is your probable diagnosis? Accelerated silicosis, anthracosis, bagasosis, chronic silicosis.
D.
D.
Yes, right answer is D, that is chronic silicosis, because if there is more than 10 years of exposure, then the development of symptoms, they are of chronic silicosis. MCQ number 4. The patient XYZ visited a pulmonologist with complaints of cough and blackish sputum. His PFT showed slight decrease in FVC. His chest X-ray showed 1 to 2 mm nodules all over his lungs. On taking history, he told he was a coal miner for last 7 years. Which of the following is not true in this case? His condition is irreversible. His disease would progress if his exposure is not stopped. He is suffering from complicated coal workers pneumoconiosis, or he is suffering from simple coal workers pneumoconiosis.
C.
C.
Yes, the right answer is he is suffering from complicated coal workers pneumoconiosis. This is not true in this case. This is the typical clinical picture of simple coal workers pneumoconiosis. MCQs number 5. Some of the workers of the coal industry ABC started developing cough, extreme shortness of breath, and fatigue, due to which they were not working properly. All were sent to the physician for medical checkup by a company, who further referred them to pulmonologists, making a diagnosis of coal workers pneumoconiosis. Which of the following is the best way to differentiate between simple and complicated coal workers pneumoconiosis? Size of opacities on lungs in chest X-ray, severity of symptoms, years of exposure in the industry, and pulmonary function test.
A.
A is the right answer. Although all can be used to differentiate, however, size of opacities on chest X-ray is very best way to differentiate. As I have told that in simple one we have less than 1 centimeter opacities in chest X-ray, while in complicated type we have greater than 1 centimeter opacities. MCQ number 6. People working in textile industry are prone to develop a crippling lung disease due to inhalation of cotton fiber. The development of vicinosis can be prevented by all of the following except periodic medical examination, good personal hygiene, promoting dry cutting and prohibiting wet cutting, conducting air monitoring frequently.
C.
Yes, right answer is C, because the best way to prevent the development of byssinosis is promoting wet cutting to prevent the air contaminant. MCQ number 7. A middle-aged man working in shipyard industry for last 14 years developed cough, hemoptysis, shortness of breath, hoarseness of voice, and weight loss. He went to the hospital for his checkup, where he was diagnosed a case of mesothelioma. Which is the main cause of mesothelioma? Silicosis, anthracosis, asbestosis, farmer's lung.
C.
C.
Asbestosis.
Yes. The only main cause of mesothelioma is asbestosis, and one of the clue for this option is that he was working in shipyard industry, so he was having exposure to asbestos. MCQ number 8. Silicosis is the most common occupational lung disease caused by inhalation of dust containing free silica or silicon dioxide. Which of the following is not correct about it? It is not a reversible disease. It has a strong association with smoking. It has strong association with duration of job exposure. It is of two types, acute and chronic.
D.
Yes, D is the right option because it has three types: acute, accelerated, and chronic. MCQ number 9. Silicosis is the commonest lung crippling disease that has no cure but can be prevented. Which of the following is the best preventive measure when dust level is above the recommended dust exposure? Substitution of silica with other metals, wearing goggles and ear muffs, frequent costume changing and washing hands at work site, wearing a respirator.
D.
Yes, right answer is D. Although A and C are also the preventive measures, but when the dust exposure level is above the recommended levels, then there is recommendation of wearing a respirator, either full face or full body respirator. MCQ number 10. Um, 40-year-old man working in grain market for last 20 years started presenting with history of recurrent infection for last 1 year. His test X-ray showed pulmonary fibrosis. The likely diagnosis was tuberculosis, silicotuberculosis, bagasosis, farmer's lung.
C.
Farmer's lung.
Farmer's lung. D is the right answer because the man was working in grain market. He was in exposure to the grain dust. This is the key of my MCQs. These are the references. Thank you.
Thank you very much, Dr. Meha. Very nice presentation, and especially the health aspects of occupational health and the diseases that are by the inhalation of coal, silicosis, asbestosis. They are very, very important from the point of the health of people, or from the point of view of community medicine, as well as from the point of view of any examination. I would also like to have this presentation to elaborate about the differences between the asbestosis, the fibrosis due to silicosis, and about the other types of, like eggshell appearance in silicosis, the fibrosis due to the lead, the fibrosis due to asbestos, blue asbestosis, etc. The one thing that I really appreciate about this presentation is that you have done a very good job in explaining the emphysema and how the emphysema is different from pneumoconiosis. We know that emphysema is basically the dilatation of the airways and the alveoli and the breaking of the walls of the alveolar sacs that leads to emphysema. On the other hand, the fibrosis is more prominent in other forms of dusts and pneumoconiosis and different occupational health diseases. So I would like you to please have slides that highlight the differences between the emphysematous and fibrotic lung due to different dusts and occupational health hazards, and so that the students can clearly see what are the differences.
Okay, ma'am.
Overall, it is a very good presentation. Thank you very much, and Allah Hafiz.
Okay, Allah Hafiz.